Dr Naomi Potter is a GP by training with a specialist interest in menopausal care. Naomi has worked in the NHS for 16 years and is a GP with a specialist interest in menopause and women's health for 9 years. Dr Potter is a diplomat of the Royal College of Obstetrics and Gynecology and Faculty of Sexual Reproduction and Reproductive Health. She is a member of the Royal College of General Practitioners and a member of the British Menopause Society. That was quite a mouthful.
Incredible.
Oh, welcome. So good to see you.
Welcome.
Thank you. Lovely to see you too.
Can we talk about the basics of how hormones can impact mental health?
Yes.
If we can start off there.
Yeah, so hormones in women can have a profound effect on mental health. And probably it's because they change so much with different stages in life. And because we have a cyclical hormonal change, and it's probably those changes that cause the impact on mental health, whether it's PMS or whether it's postnatal depression, whether it's the changes that occur during the perimenopause and menopause, but they can have a huge impact that often goes unrecognised.
Okay, and so what are the symptoms, what are the sort of typical symptoms that a woman might present that might be misdiagnosed as another mental health issue?
Well, I guess it depends on where in your kind of reproductive life you're talking about. So in the perimenopause or menopause, sometimes the only symptoms that women describe or experience is that of anxiety or low mood or tearfulness, even without necessarily being sad.
Yeah.
So those are the kind of typical, I can't cope, I can't deal with it, I don't feel myself. Those are the kind of common presentations.
So how would you decipher then what is a hormonal issue and what might be a mental health issue?
That is what is so hard, and that's what a lot of women just end up not getting the right care, because you can, especially women in their early 40s, they can suddenly start to feel these symptoms, it's not me, I don't know what's wrong. And they can go to their GP and they can be told, well, you're too young for it to be the menopause. And they can even have blood tests done. And blood tests don't always reflect what's going on. So you can have normal looking blood tests, but still be deficient in estrogen, which is what causes these symptoms. And women can be like that for years. They can be absolutely at their wits' end before they're diagnosed, and if you present like that when you're in your early 50s and you've got other things going on, so your periods might be changing or you've got other symptoms that suggest it's the menopause, then people tend to piece it together better. But it's the women who are earlier on that it tends to just slip through the net.
So how would you know that it was estrogen?
Well, it's very hard, but sometimes the only thing you can really do is prescribe estrogen, and then you see the massive benefit. But GPs particularly are very nervous about doing that. If you've got a cyclical, so say you've got worsening PMS, that can be an indicator, but it's not always the case. But worsening PMS, even in your early 40s, can be a sign of low estrogen.
And how long do you have to take the estrogen for before it starts working?
It's very
different for everyone.
It really depends.
Yeah.
It really depends. Some women notice an effect very quickly, and others it can take months. And often the medication can need some tweaking, because and that can take longer, because if you've got women that have got the kind of mental health manifestations of low estrogen, often they've had PMS as well, and so they can be progesterone intolerant. And so if you have to give women progesterone as part of the hormone replacement, and so that can kind of complicate the picture. So it's often not straightforward, whereas if you've got your kind of average woman who's in their early 50s, who've got the typical hot flushes, night sweats, and you give them estrogen, they quickly respond. But these women that we're talking about can take longer.
It's fascinating, because I thought that, I mean, when I've been to a doctor in the past and said, can you do me a blood test my hormones? They said, oh no, there isn't one. You know, you can't take, your hormones be all over the place. You know, my normal GP, and then they won't test me. But is there one that, you know, do you have to go in at a certain time in your cycle, or to get the hormones to register so you can see what needs to be done?
So if you're over the age of 45, the current guidelines are that you don't need any blood tests to diagnose the menopause.
That'd be me then.
If you are symptomatic, no matter what those symptoms are, if they are menopausal symptoms, then you can be started by your GP on HRT without a problem.
Okay.
In women who are younger than 45, it can be useful. And the two tests that would commonly be used would be your FSH, which is your follicle stimulating hormone, which is the hormone that your brain pumps out to your ovaries saying, go, 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 you know, starts developing a follicle ready to ovulate. So that's one test. That's probably what you've heard of as being the menopause blood test.
Yes.
Because if it's very high, then you are likely to be postmenopausal. Okay. The other one that is very useful if you are a specialist is estradiol, because especially if you've been replacing estrogen in somebody, it can be helpful to know whether they are absorbing it well. Mm-hmm. So some women are poor absorbers through the skin, and they can need a higher dose patch or gel to replenish the estrogen, and it's just a useful yardstick. But for a GP kind of GP consultation, if you're over 45, you don't need a blood test to diagnose it. Does that make sense?
Yeah, it does. Yeah, totally. So would a woman's family history impact her chance of having hormonal related issues towards midlife? Sometimes
you see it a lot. You really do. So women who have bad PMS often describe their mums or their sisters or their aunties having really suffered. Women who have bad menopauses in terms of mental health associated symptoms can remember back to when their mother was kind of going through the menopause. And I had a patient this week who said that she suffered terribly with PMS. She remembers her mother ending up in a mental institution at the time of her menopause, but nobody put two and two together. And you hear that a lot. You hear it a lot.
What are some practical tips that people can do if they have hormonal mental health related issues?
I mean, they need specialist help. This isn't what a GP can just prescribe an SSRI for. And in order to get beyond the GP, it's really, really helpful to have a really good history. And that history needs to correlate hormones with symptoms. So if you suffer from PMS as a teenager, if you had your best time when you were pregnant and then postnatal depression, if you struggled when you took the pill, or particularly the progesterone-only pill, if you're in your 40s and your PMS is getting worse, those are women who need kind of specialist, rather than psychiatric intervention. This is a hormone condition. This is a hormonal cause.
And what would people be feeling if they feel like that? What will people be feeling with bad PMS?
So in the run up to your period, you feel low, tearful, often bloated, can't cope. Women sometimes get very angry, and they can get suicidal. You have suicides over this.
That's the shocking part, that it can go to that extreme without being diagnosed as something that's hormonal. Unbelievable. Gosh. What else can we ask you, Naomi? Because it's fascinating having you here. I'm just seeing some of the questions. I'm like sort of processing it all in my own head, keep thinking I have to go and see Dr. Naomi. But I know. But so really, it's the main symptoms that could be that you're going into menopause, or the levels of anxiety, the sort of feeling that you're in an incredibly low mood, that you're not sleeping properly.
Those are the kind of mental health manifestations.
Yeah.
I mean, the menopause can present in, with about 50 different symptoms. But in terms of the mental health symptoms, rage, anger, just this uncontrollable rage, and you've got absolutely no idea where it comes from. But yeah, that's often something that people describe. Being irrational, poor sleep, anxiety, like an overwhelming anxiety. So women who've been able to drive on the motorway for their entire lives suddenly can't even get in the car, or certainly not go on the motorway, can't go on public transport, don't know why, just make huge anxiety.
Why is that?
So, sorry?
Why is that? What happens to your body when that happens? When you feel
it's a result of low estrogen. You have estrogen receptors throughout your entire body, which is why the drop in estrogen at menopause can manifest itself in so many different ways. So it's simply a low estrogen and or a low testosterone, but often those symptoms are estrogen.
So is that similar to PMS?
It is. I mean, PMS tends to be more a progesterone sensitivity. So towards the end of your cycle, before your period comes, you have your progesterone levels go up.
Yeah.
And it tends to be that progesterone insensitivity that gives you bad PMS, in the same way that when you replace the progesterone as part of HRT, some women can't tolerate that part of it.
Right.
So it's estrogen loss, progesterone insensitivity, and then massive overlap throughout your reproductive life. So when you're younger, it's PMS. When you're pregnant, you're better because you've got high estrogen levels, and then postnatally your estrogen levels drop. And then when you're perimenopausal, your estrogen levels drop. Does that make sense? Am I talking sense?
Yeah. Can you explain perimenopausal and what the difference is with the menopause?
The menopause, the perimenopause, it's not a line in the sand. Some women like to know, am I postmenopausal now? Does that mean I've been through it? But really, it's just a gradual decline and a gradual drop in hormones. You're postmenopausal when you're a year after your last period, but the perimenopause can last for years and years. From your early 40s, your estrogen levels drop. And so it can be a very gradual process that almost just sneaks up on you, and you might think, oh, actually, you know what, I have had a night sweat this month, and then nothing will happen for 6 months, or your periods, you might miss a period and then it have 6 or 9 and not notice it, and then
that's
and
the
then
interesting
another
thing,
one.
like the sort of stop-starting of symptoms.
Yeah.
Where you can
Very
feel
common.
sort of anxiety-ridden night sweats, and then it's like, oh, it's all gone, and then it comes back again.
Yeah.
So it can be sort of confusing, thinking, oh, maybe that's just a phase I was going through where I felt that anxiety-ridden or a bit low or whatever, but then it comes back.
And it is, I'm sure, to do with surges in ovarian activity. And you can sometimes see it on people's blood results. They might come to see you and you might do an estradiol level and it's low. And they say, well, you know what, that's really funny because that's totally correlated with my symptoms. And then a couple of months later, they're feeling better and their levels are up. It does tend to correlate.
Do you recommend any supplements or anything that people can take?
Not typically, to be honest. If my patients are fit and well and they eat a balanced diet, and typically they are, no. I mean, I do as part of, so if I've started somebody on HRT and I want to monitor their absorption, I do a group of blood tests that will indicate if somebody has got particular deficiencies. So I would do a B12, a folate, an iron, vitamin D. And so if any of those deficiencies showed themselves at that point, then I would. But as a routine,
No.
I don't know.
And what about like a change in diet or nutrition?
Again, most of my patients do have a balanced diet, but if you, I certainly think it is, so menopause care is a kind of holistic, you can't just chuck some hormones at it and say, well, you can do whatever you want with the rest of your life, this will sort you out.
Yeah.
It tends to be, if you do eat a balanced diet, if you are fit, if you do exercise, if you reduce or eliminate alcohol from your diet, you do notice the kind of positive impact of those.
Yeah. And is that the same for PMS as well?
PMS is a bit different because PMS is yes, I would always advocate a balanced diet and a healthy lifestyle. And PMS, some supplements do work, so evening primrose and starflower oil are helpful, or can be helpful, but it's the cycling effect that causes the problems with PMS. Whereas with perimenopause, it's just the dropping and then absence of hormone. Does that?
Yeah, that helps.
Totally.
Yeah.
There's loads of questions actually, Lisa, because we've got a little bit of time.
Yeah.
So someone's actually just written in, I don't know if you can answer this, Naomi. Could you speak about anxiety in menopause for someone with existing mental health issues like bipolar disorder? You got any thoughts on that?
What would be interesting is to know what her bipolar disorder history was, because there is a lot of misdiagnosis of bipolar disorder in women who actually have PMS. And so there is absolutely no reason, if they are a true kind of psychiatric patient with bipolar disorder, there is absolutely no reason why they can't have HRT, no reason at all. So the two can be treated alongside, but it would be very interesting to know, to delve a little bit more into their history. Or anyone who came to see me who said that they had pre-existing mental health issues, I would always delve deeply into that history. You know, I still patients this week who have been diagnosed with personality disorder, bipolar disorder, depression. And I said to them, you know, how was your pregnancy? Well, I felt absolutely brilliant. No problems at all.
So that's a key question to ask, because they are in the state of being pregnant, their hormones are.
Yeah, you have high estrogen levels and instability, and and then typically bad postnatal depression.
Interesting, as it drops back down again.
Yeah, or when you stop breastfeeding, so the breastfeeding kind of eliminates your cycles, and then as you stop breastfeeding and your cycles then return, that can be and
that is a question that is not often asked or taken into account, sort of in a.
It's really hard, and again, there's not a huge amount of awareness, and things like bipolar disorder and depression tend to be the remit of the psychiatrists, and there's not a lot of overlap between psychiatry and obs and gynae. I mean, you know, one's a surgical specialty and one's like the least, you know, they're, you know, almost polar opposites, so they don't they don't not a lot of overlap.
There's an awful lot of people who are loving this conversation, Naomi.
Laughing, did you say?
No, loving.
Loving.
They've all been sort of waiting for you to speak. So this is clearly a very relevant issue for a lot of people. So someone was just saying here, Dr. Naomi was describing about, I'm so glad to be here, can relate to everything Dr. Naomi's described, particularly related to my mother's experience. Let me see. I'm 14, just started HRT. And on a Facebook group, and the amount of women struggling with mental health issues is wide-reaching. Yes, this is very interesting. I certainly get the rage. Isn't it interesting? I mean, are there some people that would be more prone to getting the sort of anger outbursts than others? I mean, would some sort of go more into, I suppose it depends really, doesn't it, on the nervous system a bit, because some people are more prone to go into sort of collapse mode, if you like, where they shut down, and others can stay in sort of sympathetic, where they're in fight or flight for quite a long time. You know, what would you say about
I
that?
think part of it just depends on your personality, doesn't it? And whether you are, whether you veer towards kind of retreat and isolation, or whether you are more kind of expressive in your emotion.
Yes. Yeah, absolutely. Yeah, certainly agree. Is it just lack of training for GPs? It seems to stop them thinking of hormones first and sends them to antidepressant. It gives antidepressant meds for patients. That's often a thing I've heard.
I'm so sorry, my computer just did this. I'm going to update in the middle of that. I'm sorry.
Someone was just asking, is it lack of training with a lot of GPs? It seems to stop them thinking about hormones, and instead they just prescribe medication for depression, like SSRIs.
I don't think it's fair to say it's hard. I mean, I don't think it's GP's fault. That's I would be very vocal about, because when I did my medical degree and my obs and gynae training and then my GP training, I didn't have a single clinic or learning session about kind of hormones and mental health. So I don't. It's just one of those areas that's just again, it just falls between psychiatry, obs and gynae, general practice. It's just that pothole in the middle. I mean, definitely, I think we should increase awareness. Definitely. But and that's what we're trying. I mean, that you know, Lee, that's what we're kind of trying to do, isn't it? So I would say, I mean, maybe it is a kind of flaw in the training, but I certainly don't think it's the doctor's fault.
Yes, it's more a training, a modality of sort of training, isn't it?
I think, and it's also, it probably just doesn't even get the airtime. You don't read about it in journals. It's not on, training programs.
Someone was just asking here, are there any other options for HRT estrogen? I don't think I can have them, as my mum had estrogen-linked breast cancer.
Having a mother with estrogen-linked breast cancer doesn't preclude you from HRT. There are alternatives depending on symptoms. So some drugs you can use for hot flushes, other drugs you can use for mood, other drugs you can use for dryness. There are things that you can, and there are complementary therapies as well. There are other things that you can use, but having a mother who had estrogen receptor positive breast cancer does not mean that you can't. I mean, of course, I can't give specific advice to her, but a lot of women are under that misconception that, if they've got a relative or even two with breast cancer, it means that they can't, and that's just not true.
So it's a sort of a bit of a myth to be busted, really. Yeah. And someone was saying, agree, it's not the GP's fault. They need training to spot the signs. My surgery is really good, but have been slow to help with this. There's so many questions on here. Do you want to read me out, Lisa? Can you see them?
No, I can't see them actually. I've looked.
You can go down the bottom to, I think, to chat. If you click on chat, you can see them there.
Oh, okay.
I don't know if you can, Naomi, but
I can.
Okay,
We've got loads here. Okay. How long on average is HRT required? Is it lifelong?
So that's a really interesting point, because lots of women come to me saying, I've been to my GP and they want to take me off it. They won't give it to me anymore. They won't give it to me anymore. There is no reason why you cannot stay on HRT for life if you are well. And I fully intend to. It's as you get older, as we get older, our estrogen requirements can decrease. And so you would have an annual review and go over, what your dose is. Would it be reasonable to drop it a little bit? Because you would only want to give as much as required. You wouldn't want to give more than is required. But I've had women in their 70s and seen women in their 80s and 90s still on HRT.
It's amazing, isn't it? Yeah, absolutely. Are there any other questions there you can see, Naomi, that you would be willing to answer? Because there's so many. I don't know which ones you feel would be.
Oh gosh, my psychiatrist said of her 25 years, she's never heard of peri or menopause as a reason for mental health issues. I find that utterly shocking.
That is quite astonishing, actually. Yeah.
There's a lot of women saying they're tweaking and they can't get their doses right, and will they ever be able to? Yes. So you can. Because women are aging, and so their natural kind of ovarian function is changing all the time, it can be a challenge to keep up with where they are, especially during the perimenopause. But once women get beyond, after the age of about 55, it's much easier to control. But it doesn't, and kind of get people totally stable. But it doesn't mean that during that time it is always going to be turbulent. Some women are very straightforward to manage and to replace, and others less so. But just because you've spent 6 months or a year tweaking meds, tweaking the estrogen, tweaking the progesterone, adding in testosterone, it doesn't mean that it will not stabilise. And I would urge you to persevere. Do persevere, because that's the other heartbreaking thing, is when you see women coming in and just saying, I'm just not trying, my GP won't try anymore, I'm not going to try anymore. But do.
What would someone would come to you at what point? Would they go to their sort of GP first, and then because your approach is very tailored, isn't it?
Yes, I mean, you can. So your GPs can prescribe HRT with no problems at all. And what I tried to do in my practice was to kind of educate them as to giving kind of gold standard HRT. So as in not starting people on oral estrogens would be the first step. So if you were going to your GP, there's no reason why they can't start you on HRT, but make sure that they give you the estrogen in the form of a patch or a gel. I mean, that's probably
How would you use the gel?
Pardon?
Sorry, how would you use the gel?
The estrogen gel, it comes in two forms. It comes either in a kind of pump dispenser that's about that big, and you depress the pump and it comes out. It's a clear, it's not a gorgeous smelling, it's almost like an alcohol gel. And you just rub it into your arms after you've had a shower, on dry skin that's not been moisturized, or onto your thighs or bottom or tummy, and you just let it dry. So, some women don't like it because if you're on kind of 4 or 5 pumps a day, it can be quite a kind of copious quantity to, you have to yes, but it's absolutely fine. It's onto kind of normal skin. There's a new spray that's just come out that is more concentrated, that I'm hearing good things about. It's very early days, but I just wonder whether we will shift more to that.
And you spray that on the skin?
Yeah. The spray. Yeah.
God, fantastic. So interesting. I mean, this is a whole subject in and of itself, really, isn't it?
Amazing.
But I hope you've all enjoyed hearing from Dr. Naomi Potter. We will we'll have to get you back on the I'm Back chat show, won't we?
Yeah, that was fascinating.
In the group again.
I'm glad.
And someone was just saying, thank you for talking about perseverance. I'm only 1.5 months into my HRT, starting on estrogen only, and introducing progesterone at the beginning of June. I need to learn to wait and be patient. Thank you. And another thank you.
It can take months, if not a year. Honestly, please persevere. It really can take a long time, and it doesn't mean that it's any fault of the patient if it doesn't, of you, if it doesn't work out quickly. It's nothing wrong with you. It's just because you've got in the background, you've got this cycle going that you've got to kind of override and kind of interfere, improve.
Yeah. So
thank you so much.
Many thanks.
Okay. Lovely to see you again.
Lovely to see you.
Thank you so much. Take care.
Bye.
Bye-bye.